to help you. Okay, so I'm going to show you how the Nclex work for those who might have forgotten or those who might not have tested before and we don't have an idea how the exam is conducted or how the exam work. I'm going to show you. I'm going to give you a short sketch here before I continue. So the Nclex is such that it's a computer adaptive test. Gertrude, are you listening?
Yes. Yes.
Okay. So it's a computer adaptive test. It's conducted for the licensed practical nurse and the RN. So if it's a computer adaptive test and it's conducted for two groups of people, we have the RN and the LPN. So this test, for those who know, is the computer is supposed to determine your knowledge level. It's supposed to determine how much of correct you get and how much of wrong you get. It's supposed to take you up and down as necessary as possible to have you pass or fail. So when you start, when you go to sit by the computer, this is what you are going to be. Your line is straight, it's flat. You have a flat line because you haven't started the exam. It cannot determine your ability at this point. So you have a straight line. Don't mind my line is not so straight because I am not using my own hand. So when you have this, let's see. Okay, so because you have a straight line like this and you are the student sitting here, you are ready to start. They have 25 questions that does not count. Those 25 questions, I'm not sure if it is content level, if it's knowledge level or comprehensive or analysis level. The other time I was talking about the questions given you in levels. These are the levels that I meant. It gives you in different formats. When they give you the first question and it's recall or it's understanding, let's say it's recall. I'm not going to go into detail with this one today, but that I will dig into it later. I'm going to give you questions that will show that this is a recall question, and a question that will show that this is understanding, straightforward, and question that will show application, and a question that will show you are analyzing to get your answer correct. This is needed for both LPN and RN to pass. You need these 4 basic steps. You need to be able to understand questions under each of these levels to pass the exam. So if you are only getting questions under recall, forget it. They are just asking you straight from the book, anatomy and physiology. They ask you what is the first symptom of respiratory or the first symptom of congestive heart failure, and you say shortness of breath. That's a recall question. Where they will trick you, they will give you the signs and symptoms, and they want you to identify that this is congestive heart failure. It's analysis. You have to use your brain. They can give you vital signs, and they want you to know what could be wrong if I have this kind of vital signs. That's where you are analyzing. So when they give you the first question, I'm not saying it's going to be recall or recognition question, but in case it's a recall or recognition question and you get it correct. So when you start your exam, you start by the computer and you start question number 1 and you got it correct. So you were here. Initially, you were here. You got it correct. Then you come here. Then question number 2, you got it wrong. You come back to the line. Question number 3, you get it correct. You start moving up. Number 4, you get correct. You move this way. Number 5, you move this way because you are getting correct. Number 6, you are wrong. You come down. 7, you are wrong. You come down. 8, you are wrong. You are dropping below failure. So this line above, down here is fail and here is pass. So you get 8, question number 8 from 7 or from 5 to 8 is wrong. You have crossed the minimum line. If from 9 you get correct, you have to start climbing back up. 10, you get correct, you come back here. You are not going to see this. This is how the computer determines your ability. That's why it's computer adaptive. 11, you get correct, you go here. 12, you get wrong, you drop back. 13, you come back to the minimum. 14, you get it correct. Then you start going up. 15, 16. So if you get 1 to 5 questions correct, and it shoots you all the way here. Let's say you are question 30, and from 20 to 30, you have gotten like 8 of them correct. You are fine. You are all the way hanging up there. Now from 31, you get wrong. You still haven't dropped to the failing. 32, you get wrong. You haven't dropped. You haven't gotten to the middle line. 33, you get correct. You jump back again. You start going up. So now you are above the level person and you are swinging back and forth. But where all the questions you have gotten, like from 20 to 30, you have gotten all of them wrong. You will be here. So you'll be here. And then you start from 31, you get correct. You start climbing. You have to get multiple questions before you get to the middle line. You have to continue getting so many correct before you come up to the passing level. This is how the computer determines your ability to pass or to fail. So where you get like, let's say 3 questions correct, they'll move you 1, 2, 3, and you get 4 wrong. 1, 2, 3, 4. They bring you back here. And then the 5th one, you get it wrong. They drop you. 6th one, you get correct. They bring you back up here. That's where most people end up moving straight to the last part. Hold on. That's where most people end up, getting to the final. You get question 1 to 205 questions, and you still wouldn't pass because you were moving back and forth, back and forth. In the last few questions that would have determined your ability to pass, you didn't stay above the line. You drop a little below. It could just be 2 questions that you get wrong. That would drop you and you fail. You go all the way till you fail. When you start for the RN, when you start here and you start getting past, you start getting them, and then you get to 75 and you are still all the way up here. They just stop you because you have passed. But when you start and then 1, 2, 3, you went up, 4, 5, 6, 7, 8, 9, 10, you drop down here. And when you if you are down here and you cannot get a series of correct in order to climb up to this line and jump over the passing level, then you cannot pass it. Yeah, do we understand? Are we making sense?
Yeah.
Who has a question so far? Because I'm going to drop this one right now and then I move on. This is just to give you a good idea of how I expect you to deal with the 75 questions. So that's why I told you it's not how many correct you get that will make you fail. Sometimes the consistency of the correct and how you understand each of the questions count. That's why they want you to know a lot of the content, to understand how to analyze the content and to bring it to the analysis and the application level. So even if you know the management of liver failure and you cannot analyze the signs and symptoms you will see in a patient who present with a liver failure, how will you make it? So it's really something that you guys need to work up to. And 80% of the work has to be done by you. Like nobody can do it for you. That's how the exam is going to treat you. So the exam is not structured to be biased. It's not structured to have somebody sit there and mark you so that I decide this question, you were almost there, or this select all that apply. You got 3 of them right and 1 of them wrong. Computer adaptive, you still get it wrong. You can get half of it correct and half of it wrong, and it's still wrong. So it's the computer that determines your whole ability. And It's not human processing. Now let's move to the test plan. I have put out, I sat here for like the past 3 hours. I've been sitting here working on this document just to give you a clear explanation before we continue with our study stuff. So with the computer adaptive, this one, I got that from the website. The websites, they make changes to it every 3 years. The other time I told you that they ask candidates who have graduated. If I went to take the Nclex this week and I passed, 6 months time, they send me a letter to evaluate them, to explain what I see in my new practice, to explain if my new practice matches with the questions I answered on the exam. That's a survey. They do a survey for the nurses who have passed the exams for the past few months. And when those nurses answer the question, so if you pass now, they're going to send you a letter in a few weeks' time. And when you get that letter, that's your survey. So you fill it back and you mail it back to them. They use that to reset the questions. They use that to reframe the test plan for the following year. Now, for those who have written and have gotten the candidate performance report, you will see percentages on them. You see that each category has a percentage. So because each category has a percentage, you need to be able to get all of the categories. You need to, and these are questions representing each category. So I want to show you today questions that represent each of the categories, that when you are studying and you read a question, your mind should be able to tell, okay, so this question is about this. But that is not what you are worried about. You are worried about answering that question correct, because that's your only key, or that's your only means of being successful on the exam. And your aim for now is to be successful on this exam. Now, the Nclex test plan was changed in 2019. So they changed it from 2019, that was 1st April to March, and it's going to end March 31st, 2023. They keep it for like 3-4 years. Let me see, 2019, 2020, 2021, 2022, 2023. That's 4 years. So I overheard it was supposed to be due, but because of the COVID, they had made a lot of changes last year as well. So last year as well, they made a lot of changes, especially to the RN side. They changed it. They needed more nurses in the system, so there were a lot of changes. So this is the current test plan we are using. So if you go to take the exam, these numbers I'm coming to show you are what your targets are to pass. So for the Nclex RN and the LPN, most often the LPNs tend to think that, oh, this one is supposed to be the RNs who study vigorously for this exam. It's supposed to be the RNs who study too much for this exam. The LPN, I have had people who had the option to take the RN and they still go to take the LPN because somebody told them the LPN is easier. You need to understand it first before it's going to be easier. There is no easy Nclex. So far as it's a national standard exam that they are conducting for every professional, every nurse, every LPN, every RN, it's not easy. You just need to be well prepared and understand your areas. So the exam, I have sent you guys one with a circle that gives the visions of the marking plan. I don't know if I sent it to this group, but that's what I'm letting you know. If I didn't send you, it's the same thing I'm going to explain right now. So we have the client needs. So what the exam is testing you is client need. Everything is client need. They are not testing you the nurse's need. They are not testing the computer's need. It's client need, what your patients need. The patient came to you to be taken care of. What is the need of this patient? So the client need, the number one client need, the Nclex has 6 categories of them. Number 1 is safe and effective care environment. This is the one that I have cut it in several pieces of videos and I put it on YouTube. You can access them. So if you never understood why I was doing that, I'm trying to tackle these needs as much as possible. And I try to keep those videos within 1 hour. That's why I have multiple of them under one topic. But if I want to extend it to like 2 hours without breaking or interruption, I should be able to finish one section. But some of the areas are broader than other areas. So whilst we are studying the content, I'm telling you, this is the focus of the exam. We are studying the content, but this is what you need to be able to understand in addition to your content. So when you have the content in mind, you should be able to put it into this one to pass or to answer questions correct. So under safe and effective care environment, we have management of care. So management of care alone for RNs, management of care for RNs is 70 to 23%. Gertrude, are you getting me? Please, if you want to take a little note, it's fine, but just make sure you get this right. This is to help you in your preparation, your studies as well. So management of care alone has to take 17 to 23%. In the LPN, they didn't label that management of care, they labeled that one coordinated care. So coordinated care is for LPN and management of care is for RN. Now let's look at the percentage. So management of care alone, RN has 23 to 20 to 17 to 23%, and LPN has 18 to 24%. Like I said, when the COVID happened, it looked like the percentages were kind of reduced or is maintained for the RNs or something. I don't know what they did, but for the RN has 17 to 23, LPN coordination of care, you need to be able to coordinate patient care, up to 18 to 24% of questions. So these percentages represent the number of questions you will get in that section. So under this section, you need up to 24% of questions. So when they are giving you the questions, that means majority of the questions you get will be under coordination of care. Now we'll come and see things that fall under this category. The next category under that is safety and infection control. You have to be a safe nurse. So for registered nurse, they have 15%, and then LPN have up to 16%. This is the most recent test plan. This is the most recent document. Now let's look at what content area does these things cover. So for you to have the management of care, 23 is for RNs, 24 is for LPNs here. You need to know advanced directives. You need to understand how to answer patient questions, how to identify client needs with advanced directives. Advocacy, you have to be the patient advocate. You have to advocate for the patient at all times. So this particular one, I remember I had made a video under it, and I think I did finish this whole portion of it. So please listen, you can go on YouTube and you listen to that. So you need to also know how to regulate case management. This aspect, case management, health insurance stuff, I haven't spoken about it, but I think I have a material prepared on it that I'm going to discuss it with you guys. And that one includes emergency and disaster planning and all those things. I have the information ready. Then we have client's rights. If you heard that video, I spoke about the patient's rights. What is the patient bill of rights? Collaboration and interdisciplinary team. I have been talking about it. If you are taking care of a patient, you should know that you are a coordinator to the social worker. You are the one who will contact the psychiatrist. You are the one who will contact your other nurse to give report. You are the one who will contact your other nurse to endorse patients. So that's coordination of care. Interdisciplinary team is for you to be able to move as an RN and then take a decision. Oh, this patient needs social worker referral. Then you contact the provider, the other social worker, or you call the social worker. This patient needs case management, home care. The patient is being discharged and discharge planning. You have seen that this patient cannot function independently at home. You have to do a multidisciplinary team coordination. You have to contact the necessary people. So this is what that means. Concept of management. You have to know how to manage. Because if you are a nurse, if you are LPN, if there's no RN on the floor, you control the unlicensed personnel. If there's an RN, you still have to be a manager of your own. Then we have confidentiality, information, and security. Patient confidentiality, we know the HIPAA law already. Consultation, you don't take individual decisions at all times. I have sat in interviews where they ask nurses, are you independent? And the nurse will say, yes, I'm fully independent and I'm this and that. Nursing is not an independent job. It's a 24-hour job. You should be able to consult other people when you need help. You should be able to talk to other providers. You should be able to report information that is necessary. Follow chain of command. Follow facility policy and protocol as well. Continuity of care, I just said that. Delegation, you should know about delegation. I have a video on delegation and assignment and delegation. You should know what is right to delegate. And then establishing priorities. This is prioritization. This is where you will see most students focusing on. Most students will tell you, oh, I need delegation and prioritization, delegation and prioritization. You see that all their steady attention and their steady focus is on delegation and prioritization. They have forgotten that all these things fall in the same category. So they focus, you see them buying plenty of books about delegation and prioritization, and they are just focusing. Remember, delegation is here, and prioritization too is here. It's all part of management of care. It does have a bigger percentage. So you need to study all the content area. If you get 24% of this and you go get 2% under risk reduction potential, you are not passing. Now, supervision, referral, performance improvement, legal rights and responsibilities, informed consent, ethical practices, information technology. This is patient information and all those things. You need to have information. You need to know what all these things are. I remember I tackled it. I gave a video under that. So I'm still working on them. I'm making a video under each of this to explain. So that once I make these videos on these topics, then I teach you the content. That's how I set it up. So I explain these ones in the videos. You need to try to listen to them, and then you learning the content, and then you are practicing with questions. You are practicing with the 75 questions as well. So as much as you can study, like I said, you have like 80% of this work to do. If you don't do this, it will be hard for you to understand. You don't want to keep going for this exam and coming back. It takes you one time to sacrifice and study. And when you are studying, don't just study. Make sure you are studying and you are studying to understand. Remove all distractors and study. Then we have example under this thing. I have separated the examples into two. I put one for LP and one for RN. I intentionally did that for you guys to see the differences. Gertrude, I hope you are listening. The LPNs are the licensed practical nurses. In Ghana, they are the health assistants. So for the licensed practical nurses, this is a question. So I have two questions here. I decided to blend them together, and then I just want to read it out. Question number one, which of the following assignments by the RN would be appropriate for an LPN? Which of the following assignments by the RN to the LPN will be most appropriate? I want you guys to answer this question for me. Okay, so for this question, I want Gertrude to answer. Gertrude, which one will you pick up? I'm not on you today too much, but so if you are the RN on the floor and you are working with an LPN, basically you are the boss, they report to you. So which of these patients do you think you give that patient to Beverly? So if you are making the assignment for the morning, which of the patients will you assign to Beverly? Whilst Gertrude is thinking for an answer, patients, I want you to go to this question. It's the same thing. The LPN, LVN knows that an assignment to which of the following clients would be appropriate. I want you guys to compare the two questions and see what is the difference in those two questions. If you can't tell me the difference, it basically tells you that there's no big difference with the RN and the LPN, even though there's slight difference when it comes to assessment stuff. So tell me, and then whilst the two of them are working on that, Emilia, I want you to read this question. So this one, I'm going to label it green. That's for Emilia. Beverly.
Yeah.
What is this? Yours, I'm going to label a maybe gray. No, it's not bright. Blue. So Beverly, yours is blue. Is that blue? Yes, that's blue. This is patience. Patience is yellow. Gertrude is the first one. Gertrude, you are the RN. You are given assignment. Which of these patients do you think you will give them to LPN? The difference is what is appropriate for the LPN. Okay, I have somebody sent me the answer. It said the difference is the RN knowing what is appropriate for the LPN. And the second one indicate that the LPN know what was in their scope of practice. Thank you. Yes. Emilia, what's your answer? Which question did I give you? Please take notice of the questions. I can't remember who has what. I only remember number one, that is Gertrude. Gertrude, I'm waiting for your answer.
I can't see mine.
Yeah, yours is gone though. This is yours, Beverly.
Yeah.
Here is another example. So take the example out. This is where your questions start from. After receiving handoff care report from the RN, which of the following clients should the LPN see first? Which of these patients will you see them first? So look at the patients. The LVN knows that an assignment to which of the following clients will be appropriate. This is patients. Patients, are you on? Patients, are you on? I don't think she's on. Gertrude. Yes. Which of these patients do you think you would delegate to the nursing assistants?
Which one then?
Are we answering? We can try these questions. Do you guys want me to answer them?
Is number 1A 4? Number 1 is 4.
Number 1 is 4.
I'm asking, yeah.
Who is asking? Beverly?
Yeah. Is it 4? I'm telling you it's 4.
Oh, you are asking whether number 1 is 4.
No, I just think it's 4.
Which one is 4?
Number 1 is number 4.
No, I want you to answer your question.
I
want you to give me the answer for this one. That's your question. Three.
I can't see mine. You can't see mine, patient.
I'm coming. Okay. This is yours. I read your question to you. After you have taken reports from the registered nurse who is gone home, which of these patients will you see first? Have you finished? So that I move for some other people to see their questions. Gertrude, are you on? Huh? Gertrude? You guys are not on? Is it possible we come on video? Because it's like I'm talking alone.
Yeah, I'm watching.
My lights up.
Huh? Which one?
Hello?
Yes.
4.
Number 4, right? I'm going to mark it
Yes.
red. That's your answer. Okay. Emilia, you are green. Which patient do you think you should see first? You have come to the floor and you have received report from the night nurse. Which patient will you see first? This question and this question are the same. They are the same. They just switch it. For this one to look like it's for RNs, and this one to look like it's for LPN, but they are the same. So read it and see the difference. RN, LPN, the questions, they're all in the same format. Emilia, what's your answer? Beverly, which one?
Number 3.
Okay, Emilia wants number 3. So this is a patient she will see.
That's mine.
You are both answering the same question, in different directions.
That's the one I chose.
Which one did you choose?
Number 3, a 50-year-old woman.
Okay, but remember your question is here. I marked your question blue.
Yeah, I choose number 3.
Why do you choose number 3 among all the patients? Why do you think that's the patient you should see?
Because she's experiencing chills. So maybe she's sick, having fever.
How about the one that is having the left-sided weakness and need a commode, and the one that had a nasogastric tube with a bowel resection yesterday?
The one number 2, a client with left-sided weakness. Is it not supposed to be done by the CNA?
Well, at this point, they've not mentioned the CNA.
Oh.
They are just asking which of the patients you will see first. That's a priority question. That's establishing priority. So when you look at this question and you come back here, this is what they are talking about, establishing priority. They are not talking about delegation. Do you understand?
Yes.
I want you to establish priority. After you have received the patients or you receive report from the 9 people, you group the patient. Who is my priority patient? So this is how this link with the client's need. Do you understand?
Yeah.
Yeah. Okay. Gertrude, can you tell me why you delegate the 55-year-old man, the LPN?
Because there's not much to do for that patient. She's going to be discharged very soon, and then.
Have you realized that if a patient is going to be discharged, let me look at what I can tell you from here. Patient need referrals. The patient will need case management follow-up. You will need interdisciplinary collaboration. You will need concept of management. The patient may need continuing of care at home. Do you realize that this patient with the word discharged today will need a lot of teaching to do? And initial teaching is never done by LPN. So the patient is stable, and the patient is ready to go home. But the patient ready to go home today, you cannot delegate that patient to the LPN because you have to do teaching.
Okay.
That sounds sometimes it sounds stupid, but that's the fact. The LPNs only do follow-up teachings. They can come to the patient, and then after you have finished teaching, then they follow up on what you have taught the patient to make sure the patient really understood it. But discharge instructions, discharge teachings, if you are there, it is your job as the RN to do it. You don't delegate this patient. So this is wrong.
There is one.
Okay, now let's come to one. Why do you think it will be one? Why will you give one to the LPN? Lower back pain, scheduled for myelogram in the afternoon. Patient is scheduled for a procedure. Going for a procedure, you have to prepare the patients. So even though the patient look like it's stable, and it might be 7 a.m. this morning because I just took report, but this is not a stable patient for you to delegate. So 2 and 3, who will you give it out? The myelogram, you have to teach the patient what the procedure is. Yeah, thank you, Sachs. Yeah, they said the LPN is not in charge of discharge. Yeah, you can type that in the group chat so that they see some of the answers. So you can put it in like to everybody so that they see. So LPN, somebody said LPN is not in charge of discharge, and that's true. It's the RN. So you have to know your job description. The LPN have to know their job description. They can go by the patient, the patient asks a question, and then the patient asks, oh, the nurse told me that somebody is going to call me. And what is that supposed to be for? She also mentioned I needed a home health nurse or home care aide to come. What do you think that is? In that case, the LPN can go over and say, okay, so they are giving you a referral to home care. So that's what the home care nurse is going to call you to discuss. That's what the registered nurse told you. And then you let the registered nurse also know that the patient probably didn't understand the instructions. They need to go back and reteach. So it's the RN who do this. It's not the LPN. Now, the patient number 3, a man, a 43-year-old male, newly diagnosed with type 1 diabetes. Gertrude, what will you do for this patient? Thank you. My answer would be 2. I wouldn't choose option 3 because the patient has a new diagnosis. Yes. So for this particular word, newly diagnosed.
That's what a nurse.
Yes. Right? Yes. Gertrude, Gertrude, are you getting the concept I'm trying to carry out here? Huh? Gertrude? Hello?
Yeah.
I'm asking you questions because you are RN. So these are job descriptions that you have to pick up. So this is what you need to answer. So on the Nclex, if you pick up this question, you would be wrong. If you this answer, if you pick up this answer, you would be wrong. Does the age of any of these patients matter to the assignment you are going to delegate? Who can answer me? Does the age, you see that all of them have ages. Does it matter to the patients you are going to delegate? Huh? Can we talk? Okay, so age doesn't matter. Age doesn't matter. So far as the patient don't have anything that is new or anything that is strange, age doesn't matter. The LPN can take care of the aged, the RN can take care of the older people. So far as they are stable, the LPN is fine. Now, question number 2, a 45-year-old woman in traction, this is traction, not traction, in traction with a fractured femur. So you had a fracture and you are in traction. If you understand what traction is and the musculoskeletal system, which we didn't talk about. So this is how I want you to learn with the 75 questions. So musculoskeletal traction, what is it? So you now go back to the skeletal system, you understand what traction is. So this is a stable patient. The patient is in traction. They have hung the thing all the way to the wall or to whatever, and the patient is in stable condition. The patient is at one place. The LPN job description will include wound dressing if the need arises. But the patient is in traction with a fractured femur. So the LPN can assess pulses. The LPN knows where to check the patient pulse. The LPN knows when the skin color starts changing. So those are stable things you delegate to the patient. But you don't delegate to the patient that is going home. You don't delegate the patient that is newly diagnosed. You don't delegate the patient going for a procedure, because these 3 patients, you have to teach them. The one in traction, they didn't say the traction need anything. If there's new symptoms with the traction, that's where the LPN cannot be delegated to. But there is no new symptom. They just said the patient is in traction because the patient had a fracture. So that's a stable patient. The patient has been taken care of. They put the traction there to help with the healing process. The LPN can check vital signs. So that's what it means. Do you understand? Any question? Can I move on? Anybody has a question? Okay. Number 2, after receiving report from the night shift, which of the following patients should the nurse see first? Oh, I think I answered this one, right? Emilia, you answered number 3 and you were correct. Yes. The patient complained of chills. Gertrude, if you were the one, how will you analyze this question? How will you analyze this question? Because nasogastric tube, the patient is even 70 years old. But they said he had a bowel resection yesterday. He had a bowel resection yesterday. Today he's stable. The Nclex don't think deep into questions. They didn't tell you after the resection, the patient is bleeding today. They didn't tell you the patient has bloody stool today. So you have no business worrying yourself what is going on with the patient right now. So because of that reason, this patient is stable. He has the bowel traction yesterday. It's like you're just informing me. That was what happened. A 35-year-old man refusing sucralfate before the breakfast. He don't want to take the medication before breakfast. So let him eat. It's not a medication that the patient can take on empty stomach or cannot take on empty stomach. It's a medication that can be eaten with food. It's a cholesterol medication. So it's fine if the patient eats breakfast and take it. So this is a stable patient, just refusing medication. And this is not a life, like right now medication, it's a long-term medication. So it is fine. It's not the patient, I will go first. A 40-year-old woman with left-sided weakness asking for help to use the commode. Well, the patient just want to poop. It's fine. That will be the second patient I will go to. Because remember, poop is a physiological need. The patient has to be able to eliminate waste. So that's the second patient you will go to, because this patient has to move the bowel. A 50-year-old woman complaining of chills who is scheduled for cholecystectomy at 10 a.m. So the patient has chills. The patient is supposed to go for a surgical procedure. Now you walk in and the patient tell you, I have chills. you have to assess this patient. You have to get vital signs. You have to check the temperature, make sure the patient is not feverish. So this is why you will see that patient, because the patient is going for cholecystectomy. Patient is going for surgery. So that's the most unstable patient at this point. You want to follow up on this patient. Now, when you read this question, which of the following patients should the nurse see first? First, this is how the Nclex will present you with questions. That means you will see all of them, but they want to know, Nclex, they don't want to know more about the second one you will see. They want to know why you will see the first patient. So if you understand that chills is a new onset or is a sign that the patient may have fever, then you go to that patient. If you don't know the anatomy of chills, and if you don't understand surgery, surgical procedure, preparing a patient for surgical procedure, and things you should assess for, this calls for you to go and study it. So, and if you know what sucralfate is, you understand that it's a medication that you don't need to bother the patient about, and you don't need to rush for that. If it was like chest pain that the patient is refusing nitroglycerin, then you have a concern. That's fine. Then when you look at the patient that had the bowel resection yesterday, the patient is stable, even though the patient is an older man, but that patient is stable. So I wouldn't rush to this patient. So this is how they'll frame these questions in the LPN setting, in the RN setting. So this one, they are telling you the RN to delegate here. Here they use the word nurse. So I could have used either nurse or LPN or RN. That's the difference they make with the questions. So if they assign you nurse, you are a nurse. So if you are writing LPN and they put the word nurse, don't wait for them to write LPN before you know. Who is the patient whose safety might be compromised? Which number is that? After receiving report from the 9th nurse, or the one using the commode. The commode will come next. That's the next patient you will see. So the patient needs help to use the commode. That's physiologic needs. And that you can do it within 15 minutes. You can go to the patient and help the patient sit on the commode within 15 minutes. They didn't ask you to delegate. So this is not a delegation question. This is also a prioritization question. The first one we answered was assignment. This was a question about assigning. So when you look here, we have assignment. I have delegation somewhere. When you delegate and you prioritize. And here you have the second one is another priority. So for this safety here that you're talking about, the safety of this patient with left-sided weakness, you will be concerned about that patient. But the one that is going for a surgical procedure and has chills, complaining of chills, is something new. So I would go do vital signs for this patient. That's the assessment. So you assess the patient, ask the patient more about the chills, and then you get the vital signs. And you quickly go to number 2, who need the commode. You give the patient the commode. So that's, if you have it in mind that this is the grouping of the activities, you should be fine. You will see this one first, and then you go that one next, because you don't want the patient to be taken to surgery, and the patient has a fever, and then they do the surgical procedure, and the patient is going to end up septic, meaning the infection was already there before the surgery. So you have to do further assessment. Now, the LPN area knows that the assignment to which of the following clients will be appropriate. So this one is the RN setting. Just to let you know, this is how they set the questions to make it look like they're different, but technically they are the same. This is the opposite of it. It's the same material when you look. So our answer will still be number 2. Here, after receiving handoff report from the RN, which of the following should the LPN see first? It's the same question here. So you see the difference between the RN and the LPN, that they can just decide to use a nurse, and it's not like a big mountain to climb. Now, the next portion of this aspect is...
Can I ask that question?
Yeah.
Why number one is not the answer? Why number one is not the answer?
This one?
Yeah. Mm-hmm.
This question?
Mm-hmm. Why is not the answer for the question?
Can you explain to me what you think? How do you prioritize sucralfate? What medication is it? Is it a medication that should be taken before meals? Does it matter when the patient take it, before meals or after meals? It's a cholesterol medication.
Cholesterol?
I think so, if I remember well.
Mm-hmm.
So it doesn't matter what time. It doesn't matter taking it with food or water. It is fine to take it. But this one just reported something. That's the new thing you haven't heard. Then you go with that patient. Number two, you are worried for safety, physiological need as well. You go to number 2 second. And then you go to number 1 before number 4. Number 4 just had a bowel resection yesterday. So today I just need follow-up vital signs. That's it. Can I move on? Any question? Anybody has a question? Okay, safety and infection control. We have accident, error. So safety and infection control is part of safe and effective environments. So under safety and effective infection control, we have accident, error, injury prevention, we have emergency response plan. This is the one that I was talking about, the disaster management, disaster planning and all those things. I have a note under that I'm going to discuss. Then we have the ergonomic principles, error prevention, handling hazardous and infectious materials, home safety, reporting of incident, event, irregular occurrence, variance, restraints and safety devices, safe use of equipment, security plans, standard precaution, transmission-based precaution, and surgical sepsis. I started this last week and I think I posted that video. So safety and infection control. You can go and listen to it and see what it explains. Here is an example for that. So for the LPN, basically the questions are the same. The first one I gave 4 examples. Here I'm giving 2 examples. So the first question is, I do have 2 different medications here, but they are both antibiotics. So there's no big deal about that. So who is going to read and who is going to answer? Clementina.
Yeah, good evening. I'm sorry I'm late.
It's okay. I want you to answer number 2. And Gertrude, I want you to answer number 1. So can we start?
Yeah. I should read it first, right?
Yeah. There should be Aaron. They're the same questions.
All right. The primary health care provider prescribes amoxicillin 150 mg PO in oral suspension every 8 hours for a 3-year-old client. The LPN enters the client's room to administer the medication and discovers that the client does not have an identification bracelet. Which of the following should the LPN take?
Okay. Patients, I want you to answer this question. Gertrude, can you, okay, let me get somebody to read and Gertrude will answer. Beverly, can you read this question for me? Gertrude, this is the question I want you to answer.
Which one?
I want you to read the first one. I'm going to put a highlight on it. The yellow one I just highlighted. And then I want Gertrude to give me the answer. And then I want Patience to answer the one Clementina just finished reading. So Patience, your color is green. You are answering the green question, and Gertrude is answering the yellow question.
Ready for me?
Yeah, I'm waiting for you to read.
The physician orders tobramycin sulfate 3 milligrams every 8 hours for a 3-year-old girl. The nurse enters the client room to administer the medication and discover that the client does not have an identification bracelet. Which of the following should the nurse take?
Okay, Gertrude, what's your answer?
Number 4.
Number 4. Okay. Patience, what's your answer? Patience?
My number is number 2. Ask the child to say the first and last name.
Okay. All right. So do we agree that these two are the same questions?
Yes.
Yes.
Okay. So if the two of them are the same questions, the tag want to look like is for RN or is for a general nurse. So in all of you are nurses. I intentionally separated them like that to make you understand that sometimes it doesn't make difference to think that I don't need to study more. You need to study to understand. Okay. So Gertrude, for you to hold the medication until identification bracelet can be obtained, that's a do nothing response. The physician has ordered the medication for a 3-year-old girl, and you enter the room to give the medication, and you don't see a bracelet band. So this medication is for safety and infection control. It's for safety. So for safety purposes, you don't want to give patient A medication to patient B. So I have another video, I think if I sent it to you guys, it explained the strategies, and I have the do nothing responses. Never choose them on the Nclex. The question that tells you to do nothing. You are just holding the medication. Remember, the doctor didn't tell you to hold it. It is time to give it. 9 a.m. is the order time. So it is 9 a.m. You walk in the patient's room. You have no reason to hold the medication. The patient needs to get it. If it's just the armband, is for safety and security or safety risk, safety reason. So you have to follow up and make sure you get an armband for these patients. So the second part, I'm going to jump from here to answer patient's answer as well. You're asking the child to say their first and last name. Now, why would you ask a minor? You know, the child is just 3 years old, if I remember the age. The child is just 3 years old. So when you are doing pediatric nursing, you usually don't nurse the patient alone. You nurse the patient with a parent or with an adult, somebody of a reasonable age. So a 3-year-old, like I have my 3-year-old right now, if you ask him his name, he can tell you his name. He cannot tell you his date of birth. So identification, you need at least 2 verifiers. You need a patient to tell you their name and their date of birth for you to know that this is safe. So once they are telling you, you are holding the medication, you are reading the order to make sure that this is who it was ordered for. So I'm going to tell you the answer is to ask the parent at the bedside to tell you the child's name. So the child doesn't have a bracelet, but you have the medication that is due and the child has to get it. You have the parent by the bedside. You have the medication right on the paper. So I'm going to ask, Mommy, can you tell me your child's full name and your child's date of birth? Then the mother will tell you, oh, my baby's name is Gonzalez, whatever. So Gonzalez, whatever. And what's your child's date of birth? Then the mother will mention December 1, 2009. So you have the medication, all that information, you verify it under the medication order. So remember the right of medication, right patients, right medication, right dosage. So now you have gotten the mother to confirm you the name of the patient and the date of birth, and you have that registered on the medication. You have to confirm, is that the correct dose for this patient? And the correct dose, you have the order the doctor gave and what you receive from pharmacy to confirm it before you give that medication. So the safest action at this point is the mother who gave the name to the baby, who is with the patient right now. Any question? If you say if you are holding the medication, it's a do nothing response. You are holding until identification bracelet can be obtained. Who is going to obtain it? In the Nclex, you don't send people. You don't wait for people to do stuff for you. Nclex is these 4 patients or these 4 instructions are all for you to make a choice which one you will do now. Yes, Beverly.
So what about answer 3? No?
Answer number 3, have a co-worker identify the child before giving the medication. Well, if I am the co-worker, if I am your co-nurse, I was assigned to this patient and I'm going home. Even if I am there, I am not the correct person. So this is how identification works. If it's a child, you ask the mother. If it's a minor, you ask the parent. Just like consent. If you listen to that video about consent that I spoke about, we have minors that can give consent, especially when they are pregnant. If a minor is pregnant and give birth, the minor can sign a consent for that baby. But if that same minor has to go for a surgical procedure for herself, and she's just 15 years old and she has given birth, she's only responsible to sign a consent for her baby. She herself is a minor, so if she has to go for a surgical procedure, her parents or somebody responsible over her has to sign. There's a principle when it comes to consent. So getting the name of the child, it should be from the mother to be the authentic source. It's not the co-nurse. So how about if I mix patient in room A's name with room B's name and I told you and you give it, you get in trouble. You give them the medication. That's medication error. So, and remember, under safety, we are trying to prevent accidents and error, which will further cause injury, and we are preventing injuries as well. So the best person to ask is the mother, since the child is a minor. So if the mother is also a minor and the mother is a 15-year-old or a 14-year-old and have been able to give birth, that is the mother. She can sign consent. She can say, I want to give consent for this. I want this for my child. I decide for my child. My grandmother or the baby's grandmother cannot decide, but the baby's grandmother can decide for me because I'm also a minor under her care. Do we understand? I will urge you, I think I posted that video. All these things I'm saying, just take notice. If you check and you don't find them, let me know. I will look for them. I know I did post them. I have a lot of videos. Sometimes I forget that I didn't post some. So I'm making up videos on these things just to have you get a feel of the real touch aspect of how Nclex want you to break down the content knowledge you have and put it into use and answering questions to pass. In the case of an emergency, would you still need a consent? It depends on the kind of emergency. It depends on the kind of emergency. If it's a life-threatening emergency, they brought you to the emergency department and you cannot talk. Let's say the homeless people, like the last time I spoke about the vulnerable population, the homeless people, somebody is found on the streets lying down, EMS brought the patient cannot even mention their names. You still need to treat the patient and you want to give Narcan, you have to give it because you want to revive the person. Like the person has or you want to do CPR and the person has the healthcare proxy by the side and tells you, oh, he has signed not to do this. Then you need proof. You have the proof. The patient said, don't intubate, no CPR, you can't do it. But if there is no living will written down, If there is no healthcare proxy on the site to tell you what it is, or you don't even consent in case of emergency, you don't need it, especially if, let me use a car accident, when there's an accident and then they bring the victims and they have some of them dying, they need right now surgery. If they need an emergency surgery, they get the healthcare lawyers involved, and then they get a court order to go on with emergency care that will save lives. That is another reason why I will tell you about the Good Samaritan law. You are walking on the street, you are a registered nurse, you see that a car just hits somebody and the person has no pulse, you can start CPR. In case you are doing the CPR and then let's say your finger accidentally or whatever, you made a mistake and the person died, the Good Samaritan law will cover you unless you did it intentionally. If you go there and choke the person and kill, Good Samaritan law doesn't cover you. You are in trouble. But if you are trying to provide CPR and in the process of you giving the CPR, the patient suffer rib fractures. The patient get rib fractures and they go to sue you. The Good Samaritan law will protect you because you are doing a Good Samaritan job. So those are special cases, especially when it comes to disaster management and all those things. We have Good Samaritan laws. That's how those laws work. So in case of emergency, if it's a life-threatening, you get an order, you get a court order to give you order, go ahead with this heart surgery because the patient is declared like deaf and dumb, or the patient is brain dead and cannot speak, and the patient doesn't have a family. So the court is ordering that, let's do this surgery, or the court is ordering you to go ahead. You can do it. That's in an emergency situation. Any question?
Yes, please. Even though we are not treating the consent now that you mentioned it, you said that a 15-year-old who is a minor cannot sign for herself a consent. What do you have to say about emancipated minor? I thought being emancipated, that they can take decisions like that for themselves.
Who is an emancipated minor?
An emancipated minor is a girl or a boy, an adolescent who has left home, who is now living like a married man, for example. You said it already, who has given birth to a child or is married. Yes. Married and living with a man, whether a minor or a grown-up. So such a person is considered emancipated.
Yes.
And for that reason, she can take this, she can sign consent for herself in case of surgery. I don't know, I'm asking.
It depends on the situation. It's a situational basis. So for a minor who is married, we have minors that are considered matured as well. So you are, let's say 16 or 15 years and you get married, you have your husband, you have your child and all those things. In that case, you break the law of being a minor to be under your parents' care. But if you're a 15-year-old and you are still with your parents and you have a child, you are still under your care, under their care. So if you are married, you are more responsible for yourself. They will now wait for your mother to come from her house to come and give consent before they do surgery on you. They will take your consent because you are considered matured at that stage because you're already married. You have your own husband, you have your own child. But where you are not married and you are still a minor and you have given birth and you are still with your parent has control over you. So emancipated minors are usually considered to give consent of their own. That's the difference. So under the video that I made about consent, I have stated it clearly for those who qualify to give consent and those who don't qualify.
Thank you.
You're welcome. Anybody has a question? Gertrude, are you understanding what we are talking about?
Yes. Yes.
Okay. Patience, are you with us?
Yes.
Any question? Any question?
No, please. No.
Okay. So the correct answer for this one will be to ask the parent. You asking the child is a minor. If you guys remember the 15 questions assessment I gave. There was one that was asking about a mother coming to the emergency with a minor and they needed interpreter system, or from whatever country, they needed interpreter system. I remember all of you got it correct, if is what I remember. But the answer was to look for medical translator. You don't use the 18-year-old to interpret. In the same order, you don't use the baby to mention their full name and their date of birth. Even if you did that, it's not right. If you have seen nurses doing it, don't do it for Nclex. Nclex want you to get the source from the horse's own mouth. Don't go cutting corners. So our answer, have a co-worker identify. This one is even off. Your co-worker, no. Your co-worker is not an identifier on the floor, okay, Beverly? Unless it's your co-worker's child. So if I am your co-worker and I bring my child, you can ask me. Okay, so now let's go to the next portion of it. So all along, we have spent all this time talking about safe and effective care environment. And under that, we have the safety and infection control, and we have management of care. And this carry about 24%. And okay, let me just mention these ones here. So it carry about 23% for Rnand and 24% for LPN. This is the management of care, or this managed care. So LPN is managed care. Rnand is management of care. So let me just separate that here. Okay, so let's talk about the next aspect. We finished safety and infection control. So you want to be a safe nurse. So the percentage is that you have to be safe enough to practice on the floor. So if you're not safe nurse, you cannot pass the Nclex. So if you go and look for your friend or somebody you know who is doing one-to-one, even if I'm sitting down doing one-to-one with the patient, you still cannot ask me the name. I'm not the best person to confirm it. So you ask, but if it's an adult, you ask the person, tell me your name and your birthday or your date of birth. And please be nice, okay? We have content area for health promotion and maintenance. That's under health promotion. So the health promotion is also another section. Rns have 6 to 12%, and LPN have 6 to 12%. So you need to get this percentage to be good on the Nclex. Now let's look at what this area covers, health promotion. I haven't started tackling videos under this, but I was making a lesson note under maternity nursing. After Rnand system, I'm tackling maternity. I'm going to tackle everything in maternity, and we are all done. So we have the aging process, we have the intra, anti, postpartum, and newborn care. Data collection techniques, developmental stages, transition, health promotion, prevention of health risks, and high-risk behaviors. We have the high-risk behaviors, lifestyle choices, and self-care. Now, this, I put the Rnand here. It doesn't mean it's only for Rnand. Everybody needs to know. We have the health and wellness, health promotion or disease prevention. You have to know infection, like precaution measures. That's the disease prevention stuff. Health screening, high-risk behaviors. If I remember, I spoke about this in the LGBT aspect of the vulnerable population. Lifestyle choices, principles of teaching or learning, self-care techniques.
I'm sorry.
Now let's talk about an example under this category. So this is the category, health promotion and maintenance. How do you promote my health if I get sick? And how do you maintain me if my sickness is chronic? How do you maintain me? So these are the things you need. So if I am older and I'm in my old age, you should understand that degenerational changes, age, the age has an impact in managing me. So when you are taking care of me, you should know. If I am a younger girl, if I am a teenager and I come to you, high-risk behaviors, smoking and all those things, you will understand more about it. Developmental stages. So if I am 3 years old, you understand that I cannot give consent. I cannot you cannot take any information from me, even if it's my head that is aching, but you have to ask mommy, what is wrong with your baby? And mother will tell. You don't take information from them, or you don't, especially when it comes to teaching. So if I'm teaching,
Sorry.
the mother.
Sorry.
So we have example. Gertrude, can you read this question for me? And Emilia will answer. And then Patience will read this question and Clementina will answer for me. So Gertrude, you can start this one. I give you yellow color.
Okay, a 25-year-old woman in active labor is admitted suit. An hour later, the membranes rupture spontaneously. The nurses observe a glistening white cord protruding from the vagina. Which of the following actions should the nurse take first?
Okay. So who did I say is answering this one? Beverly? Or
Yeah.
yes. Okay, Beverly, be reading your answer options. Emilia, are you reading or you're answering? Emilia is reading this one and Patience is answering. You're answering, right?
A 21-year-old?
Yeah, you said I will answer.
Okay, Patience, read this.
Sure.
Okay. The LPN or LVN in the outpatient clinic note that the blood pressure for a client is 190/100. The LPN or LVN should take which of the following action?
Good. So Beverly, what's your answer for this?
Which one? A 21-year-old?
Yeah.
Apply manual pressure to the presenting part and have the mother assume a knee chest position. Number 4.
I'm gonna highlight it. Gertrude, I want you to answer this question. Emilia. Oh, Gertrude, answer number 3. Gertrude, did you answer?
Yes.
Where?
Yes, number 3.
Number 3?
Yes.
Apply a clean towel over the cord and wet it with a towel normal saline. I'm gonna put green. Yeah. What's your answer? What's your answer, Emilia? Yes, Emilia, I'm waiting for you. Clementina, can you also answer? At least 2 people.
Can you bring down the question so I can?
Yeah, it's as if I can't see.
Oh, I moved it. Oh, okay. Can you see now? Can we see it now?
A little more
A little up?
down.
Okay, that's it now.
I'm waiting for your answers. Then we'll take a 15-minute break. Did I move it?
I'll take number 4.
For which question?
For the first one, the 21-year-old is number 4. My answer should be 4.
The 21-year-old?
Yeah. Because my answer is
for number 3.
Then for the second one.
I'm going to add red to mean Clementina. Emilia,
Yes.
I'm still
Ready?
waiting for you for this question.
I'll go for number 3.
Number
Hmm?
3 too for me.
For the 21-year-old
You vote for
membrane
what?
wrap.
Number 3.
Yes.
Number 3 says use. Oh boy.
Oh no, I thought the 21-year-old. Oh, okay.
Oh, so the 21-year-old, which one are you answering?
Number 3.
You are answering number 3.
And Beverly say number 4.
For an outpatient clinic.
I have Clementina and Beverly here, and I have Gertrude on number 3. Emilia, you say number 3 too, right?
Yes.
Okay, so 2. Then I have this one. Who is
Oh, answer,
using?
my answer is 3 on that one.
Your answer is here?
Yes.
Okay, Emilia, which one will you answer? Mm-hmm.
A 4.
You're answering 4 for this one, right?
Yes.
Okay, so let's talk about them. So a 21-year-old woman in active labor is admitted. An hour labor later, the membranes ruptured spontaneously. The nurse observes a glistering white cord protruding from the vagina. Which of the following actions should the nurse take? Now, what do we know about labor? I know most of us have given birth, or all of us have given birth. And you know that in labor, the baby should come first. Now you have the cord coming out first. So this white glittering thing they describe is the cord. That's how Nclex treats you. They don't want to mention to you what it is. Gertrude, are you getting it? So instead of just saying the nurse, instead of just telling you straightforward that the nurse observed the cord coming out, they describe a glistering, I think it should be glistering, white cord protruding from the vagina. And they want to know what you would do first. Gertrude, you will do all these actions. They want to know the one that you will do first thing. If you walk inside and you see this one coming out of the woman's vagina, what will be your first step? Now you said you place a clean towel over the cord and wet it with a sterile normal saline. You know that in labor, the cord shouldn't come out first. So when you place the towel with the wet normal sterile saline, what is your reason for that action? What is your reason? That looks like you are not doing anything helpful. Look like you are not helping the situation right now. And you are supposed to be the nurse, even though you are not a midwife. Nclex presented to you that the woman is already in labor. It doesn't matter, even if you are EMS worker, you are supposed to help deliver this woman at this point. So you cannot cover it with normal saline and walk out. Now, Beverly and Clementina said you apply manual pressure to the presenting part and have the mother assume a knee chest position. Do any of you have a reason why you chose this answer? Do you know why you will do this?
The mother assumed.
Or you just picked it up because it looked right?
No, my reason for taking it is because I know that the knee chest position, when a pregnant client assumes a knee chest position, it will help to push the baby further up, so that the pressure of the head will not rest on the cord and cause what is it called?
To wrap around the baby's neck?
No, not that. For the girl, and cut oxygen supply to the baby.
Okay.
Yeah.
Beverly, do you have a reason?
No.
So let me explain this. Thank you, Clementina. So the correct answer is actually number 4. The first thing you will do is to apply manual pressure. You have to try to put it back.
Yes, go back up here.
This symptom here, this presentation of what you would do is how you manage a prolapse cord. Uterine prolapse cord. So if the cord is coming out without the baby, you have to put it back. So you manually apply pressure to the presenting part and have the mother assume a knee chest position. Clementina explained the relieving of pressure aspect. So the thing that answer is telling you is how to manage a patient with a prolapse cord. The cord is the presenting part. Instead of having the baby's head or the baby's body part as presenting, is the cord that is rather coming out. We don't deliver the cord first, we deliver the baby first. So you have to manually have the cord push back a little, then you put pressure and have the mother assume that position to relieve pressure and have that baby. If you don't do that, the baby is going to go into respiratory distress because the placenta and everything is detached. That's what it's telling you. Is if it detached, it's going to be on the baby, and the baby will go in distress. So this is labor and delivery. Any question?
So could the cord wrap around the baby's neck?
Huh?
The cord. Could
Yeah.
it wrap around the baby?
Yeah, it's all part of the reasons why you want to have the mother assume a knee chest position. That's a more helpful position to assume at this point. Okay. So the cord can be wrapped around the baby's neck when it starts as the presenting part. So before you start pushing all these things, or before the lady was already in labor, the lady should have been under monitoring already for fetal stress testing and all those things. The mother will be monitored. So now this question, Emilia chose which number 3 or number 4?
3.
You chose number 3?
I chose 3, yes.
So the LPN in the outpatient clinic knows that the blood pressure for, I have a chart. Number 3?
I choose number
Yes.
3. I choose number 3.
Yeah, so for the second question, okay, let me read it. So number 3 is not correct. Our answer is number 4. For the first question, you make the mother assume a knee chest. For this question, you are the LPN in the outpatient clinic that the blood pressure of a client is 190 over 100. The LPN should take which of the following actions? What will you do first? Or what do you have to do to help this blood pressure? You report the blood pressure readings to the RN, you wait 20 minutes and retake the blood pressure. Before you finish waiting, whatever complication was going on would have happened. That's a do nothing response. So waiting 20 minutes is a do nothing response. Take notice of those do nothing responses and let them be the first questions you kick them out. Then we have use a different curve and retake the blood pressure. Why would you use a different curve? The curve has already told you the blood pressure is this. You cannot manipulate it. So the blood pressure Nclex give you is the standard blood pressure. It's not about retaking it. It's not reassessment. They are not asking you to reassess. They want you to take a step because you have just seen that it's high. So even if you use a different curve, did they tell you the curve they used was small? No. Don't read into the question. Just understand that they told you the patient blood pressure is high. You don't care how many blood pressures they use or how many curves or the size of the curve. They have already told you. They're not talking about the curve right now. They want you to do something. They want you to do something right now. So using another curve to take it, if you use another curve to take it and it's 184 over 99, it's still high. It's still not normal. So there's no point changing it. Then position the client supine with feet elevated. Why will you do this? Why will you position the client with feet elevated? Did they tell you the patient has any orthostatic or whichever type of hypertension or hypotension? So there's no point elevating. The best answer is to report the blood pressure to the RN if you are the LVN. And if you are the RN, the best answer is to report it to the provider. Get an order for blood pressure medication to bring that pressure down. There's nothing you can do. You have assessed it. And the assessment is the blood pressure you got. So the next option for you to manage blood pressure is to have it come down. So it's the option that will help with further treatment. So the RN on the floor is the one supposed to take report for that. So the correct answer is number 1. Any question?
What about 4?
Yes.
Why will you do this, Beverly?
That's what I'm asking.
Why will you position the client? What's your plan for that?
Thank you.
What has positioning got to do with reducing this 190 when the normal should end at 120?
That would be worse, right?
It basically doesn't have anything to do with it.
Oh, okay.
Yeah, it wouldn't increase, it wouldn't reduce, but that's, you are not taking peripheral blood pressure, you're not taking the blood pressure from the legs that you want to assume that. So they didn't give us any limits, let us not assume. So that doesn't just, it's not the thing you would do first, or it's not what you would do now.
In fact, you said we should not assume that the blood pressure curve was on the side. So for that, number 3 is wrong, correct?
Don't read into, don't make meaning for them. When Nclex give you the question is complete from whatever they want.
Okay.
So for you to go and look for another curve, your mind is that maybe the curve was small. Did they give you the patient body size? No. Did they tell you the patient weight? No. Did they tell you the nurse used a smaller curve? Did they tell you the size of the curve that was used? No. If they mentioned that the nurse used a pediatric curve on an adult patient, then you can go thinking about curve, but this is a complete question. You are in the outpatient clinic. This is how I want you to look at the question. So I'm the nurse right now. This is a clinic. Then you bring in your relative. And when I check the blood pressure, this is what I see on my blood pressure machine. This is what I see on my blood pressure machine. It's complete. I have done assessment. You told me you are here for headache, and when I check, this is what I found. I don't need to do anything further. I just need to report this. So for me to assume that this, you see, this is a clinical setting. Again, clinical setting, you see that the nurse would have seen that that's why when you see the patient on initial meeting, you use subjective and objective. So I've already seen you, I know your body size, I use the right curve. So on the Nclex, they don't assume you have used the wrong curve. So if you wrap up the curve on the patient and that curve doesn't fit round, that means it's small, you have to change it. And if my hand is tiny like a stick and you go wrapping a bigger curve on my hand, then you end up getting nothing. So it just doesn't make sense. Yes, somebody posted that you would do number 4 if the patient is hypotensive. Now, mostly when patients are hypotensive, you try to put them in, do I call it reverse Trendelenburg, where you put their legs up, especially when it comes to fluid management. Patients on dialysis, if I'm taking care of a patient who is having dialysis, I remember I had mentioned that in the video, a patient that is getting dialysis, if they get hypotension, if their blood pressure is low, the first thing is to stop the dialysis, give them fluids, and then you raise their legs up. So hypotension, when you do that, you are trying to bring the peripheral blood back to the brain and have the brain react, or the brain get enough oxygen supply to start working. So you do that whilst you call for help. So in case of hypotension, thank you for the answer. In case of hypotension, if the patient was hypotensive, then you try to bring all the peripheral blood, the blood on the legs, you're trying to have them all come back up to the heart and to the brain to supply enough oxygen to the brain. So it's only in hypotension you'll be worried about this kind of extension, elevating legs, but this is hypertension, you will not be helping. So it doesn't have anything to do with the high blood pressure, you will be causing more harm than good. So you don't want to even try that. Do we have any further questions, contributions? Huh? Let me see our time. Oh, our time is up. Okay, so client need. I want to finish this thing today. Client need. So we have the client need. RN is 6 to 12%, and LPN is 9 to 15%. Are we seeing the percentages?
Yeah.
Okay, so RN is 6 to 12%, LPN is 9 to 15%. And under this psychosocial integrity, yeah, I was mentioning client need number 3, psychosocial integrity. So under this one, we have abuse and neglect. We have behavioral management or interventions, chemical and other substance dependence. We have coping mechanisms, crisis intervention, cultural awareness or diversity. I tackled this topic before. End of life care, family dynamics, end of life concept, grief and loss. That's the stages of grieving process. So if they present to you, they'll tell you a patient is this and that and that. What will you tell the patient? We have the mental health concept, religious and spiritual influence on health, sensory or perceptual alterations, stress management, support system, therapeutic communication, and therapeutic environment. Now let's answer questions. So under this one, a 52-year-old male comes to the nurse's station and asks the nurse if he can go to the cafeteria. Gertrude, I want you to answer this one as well. A 52-year-old male comes to the nurse's station and asks the nurse if he can go to the cafeteria to get something to eat. When told his privileges do not include visiting the cafeteria, the client becomes verbally abusive. Which of the following approaches by the nurse would be most effective? Now read the answer options. Emilia, can you read the next question? While Gertrude is thinking of her answer, Emilia. Okay.
Yes.
Read the question that I highlighted, so that Gertrude will be thinking about the first one to give me an answer.
A client comes to the nurse's station and inquiries about going to the words are too small for me. I can't even see them. Wow.
All right. Good. Or bigger.
A client comes to the nurse's station and inquiries about going to the cafeteria to get something to eat. The client becomes verbally abusive. When told personal privileges do not include going to the cafeteria, which of the following appropriate approaches by the LPN or LVN would be most effective?
Thank you. Clementina, can you answer the second one? Gertrude, what's the first answer?
I'm thinking of 2.
2. Ask what the client wants from the cafeteria and have it delivered to the client's room. I highlighted. Clementina, what do you
Yes,
think?
I sent an answer for the 2 of them, the same thing.
I know, the 2 of them are the same.
Yeah, I sent an answer on the chat.
Put it to everybody. I see a direct message. Your answer number 3. Yeah. Yes. So Let's answer it. So ask what the client wants from the cafeteria and have it delivered to the client's room. This is not what you would do. Most effective. That means all of this will be effective. They want you to pick the most effective one, the most of all. So tell the client to speak softly to avoid disturbing the other clients. But listen, this client is already verbally abusive. How will you even ask him to speak? To be soft. For all you know, something is going on here, you know. Most often you don't want to tackle that. Assign the assistive personnel to accompany the client to the cafeteria. This is not a client you will assign to somebody because safety purposes, you don't want to assign this client to anybody. The clients basically need to go back to their room because their privileges have been restricted. Before you now start asking the client, what do you want? What can they order for you? So the client can have somebody go order it, or the client can have a relative bring the food for him. So calmly and firmly escort the client back to the client's room. So the person is verbally abusive, insulting you, you black bitch, black monkey, black this, you know, mostly. So you have to help send the client back to cut all this aggressive behavior or these abusive words. Sometimes it's irritating when you're in the real practical world. It's really irritating, especially when you're helping the person, right? But that's it. That's the next thing for you. So the correct answer is number 3.
Which one?
Sat and Clementina. Huh?
Oh, okay. Which one is the answer?
Number 3.
Right.
To escort the client back to their room.
Yeah, so he's abusive.
Is it?
So he's abusive.
Yeah, you want to cut it.
Yeah.
So you'll be like, okay, relax, calm down. Let's go back to your room and we talk more about it. And you get them to their room and then you can do any of these ones next. But to have somebody accompany the client in this state, this verbally abusive state, then before the person get there, we would have kicked him off. So you don't want to do that one, Gertrude. Now let's go to the physiologic integrity. Now physiologic integrity has subdivisions, and that one is divided into several other options on the Nclex. Oh boy, how do I put this back? Okay. So this is physiologic integrity. And under physiologic integrity, we have 4 or 5 of the 4 subdivisions. So physiologic integrity alone, we have basic care and comfort. Rn is 6 to 12, LPN is 7 to 13. Pharmacological and parental therapies, Rn is 12 to 18, LPN is 10 to 16. We have reduction of risk potential, Rn is 9 to 15, LPN is 9 to 15, the same thing. Then we have physiologic adaptation, is under physiologic integrity. It's 11 to 17 for Rn and 7 to 13. So let's quickly look at these ones. I have one example on each of these ones and then we can close for the day. I'm sorry we didn't get a break. Basic care and comfort, nursing actions that are covered in this. So basic care and comfort is this one. It's up to 13 for LPN and 12 for Rn. We have assistive devices. We have elimination and mobility, non-pharmacological care, comfort interventions. This is end of life care or stuff. Nutrition and oral hydration, personal hygiene, rest and sleep. So you need to know topics under this. I'm going to make videos to cover them and I'll send it to you. So example of this will be what? Can somebody read? So instead of having those same questions repeated above, you see that they will use the nurse, and then I use another one for the LPN. So instead of that same question repeating itself, I just put the nurse or the LPN here. So this is how the questions come. So if you are taking it for LPN and you are registered in your name as LPN, all the questions you will see, they will put LPN or they use nurse. If you are RN, they'll put nurse, and that's it. So most of the questions basically, apart from the assessment component and the teaching, initial assessment, the initial teaching, LPNs do follow-up teaching. So that makes a difference in the exam. So can somebody read this? Beverly, yeah, for a while. Can you read this question for me?
Which one?
The yellow.
The primary healthcare providers applying a cost to an infant for treatment of Talipes, equinovirus, which of the following instruction is most essential for the nurse, LPN, and LVN to give to the child's parents regarding care?
Patience, what's the answer? What's the answer? Patience. So I want you guys to start thinking, who is an infant? And what is appropriate for an infant? This is content. That's why I have you focus on the content. So you know that an infant, you should know who an infant is. They have mentioned Talipes equinovirus. Do we know what it is? Do we know what it is? And does it make a big impact on this question? Does it affect what you're teaching the mother if the child has a cast and is an infant? Patients,
Is it a malformation of the feet, right? Of the leg, around the foot area?
Mm-hmm. But does it have an effect on the fact that the child has a cast? The child is supposed to be an infant. So if an infant, they're only telling you this was the reason why they put the cast on. But the concern now is what teaching, how you would teach the parents to take care of the child. Do we understand?
Yes.
So what will you teach the mother about? Patients, tell me your teaching. What will you teach the mother about? And who is an infant? So if you know the age appropriate of an infant with a cast, or the age appropriate for an infant, and what to tell the mother. It's a general for that age. Stages of growth or developmental stages of growth. Patients, what will you tell the mother? So if I am the mother and I bring my child and my child has a cast, if you don't know that the child is an infant, I tell you my child's age. So you know my child's age. What is the appropriate action for you to take? What will you tell me to go home? I don't think patience is gone.
So let me ask for clarification. When we have a question like this, are we focusing more on the assistive device or on the client, on the patient? Because if we are focusing more on the assistive device, then we should be asking the mother to visit the clinic frequently for cast adjustment.
So for the purpose of the Nclex or the purpose of Nclex, you are not given a limitation to teach this mother. The only teaching instructions they have given you is these 4 answer options. So these 4 answer options will either be for the cast or the patient. But remember, all what we are talking about is client need. All of them is client need. That's what exams want you to know. They want you to know that the patient is your priority, regardless of whatever is going on. So if I have a cast, under normal circumstances, I shouldn't have a cast. So if I have a cast and you are going to educate my mother, you are educating my mother because I have the cast. So you cannot say, go and do cast care. But you know everything is because you want it to heal or you want me to be safe. So you cannot separate it. You cannot think deep into this question. Do you understand? So you don't have to think deep to ask yourself, is this question talking about me teaching the mother about the cast or about the baby? No, it's about the fact that the child is an infant, and the infant has not got anything to do with the cast. But you know that if the infant is the one that has the cast, you cannot teach the infant. So it's the mother you have to teach. So which of the instructions is most essential, most important? So if I say, don't, make sure your child does not dirty the cast. Oh, I see somebody answer number 2. Thank you. Make sure the child does not dirty the cast. Is it most essential? Do you know what a cast is in the first place? And do you know a patient carry a cast for at least up to 6 weeks and above? So the cast is usually in place for a long time. And the cast is on an extremity that you need blood flow. So if you need blood flow to the extremity, and I'm going to educate this mother, what is priority right now?
That's 4.
Check
That should be 4
circulation.
then.
Check circulation, huh?
You see, I gave you the answer, right?
Check circulation.
I gave you the answer. So
Right.
when you read all these answer options to make you understand what the question wants, this is how the Nclex will twist the question. They give you the information. They want you to figure out what is necessary right now. What do I do right now as the nurse? So even if you are sitting down as a nurse, you're minding your business, the mother bring a child and tell you, my child had a cast since last week, and I'm here to just check. Everything looks good, everything is fine, but I just want to check and make sure it's in place. You still need to check for circulation, even if the mother don't tell you. So how much more than if you are the one caring for this woman right now, and the cast has been applied for the child. So even though it's a child, even if you are an adult and you have a cast, you still need to check circulation. So regardless, a cast is a cast. Usually, the main concern for having a cast on is circulation and infection.
Is this ABC?
We don't have ABC in cast.
Airway breathing circle. Okay.
Cast is more of circulatory problem.
Okay.
So offer age-appropriate toys. So if the child has a cast and is going home, what has that got to do with me offering age-appropriate toys? The child is 3 years old. That was why I asked you, an infant.
1 year old.
Who is an infant?
0 to 1 year, 0
Yeah.
to 12 months.
So how will offering a toy to an infant do to the cast that the mother should care for? Can an infant check? You understand?
Yeah.
Visit clinic frequently for cast adjustments. Yes, you will tell the mother all these things, but the one the most essential, that's what I said. Remember, so far as there's a cast, there's a traction, there's something new on your skin that is giving pressure, you are worried about circulation. So number 4 is correct, I know, but all these things you will do, you offer age-appropriate toys, that's fine, I will do that, but I'm not crazy for that one right now. To visit in the clinic frequently for cast adjustments, yes, you want the mother to continue following up with the clinic for them to have frequent check and see if it needs to be adjusted, because the child is growing and the hand is getting big, the hand too is growing as well. So if I am a child and I have a fracture and they have the cast on, but my body is still growing, I'm just 1 year old, I'm just an infant, gaining weight and increasing. So as the child increases, the cast will need adjustment. That you will tell the mother, but that is not the right now need. You understand? It's part of the education. Given an analgesic as needed. As needed, is the child in pain? Is the child crying? You tell the mother, if the child is in pain, give this. But you still need to follow up with the clinic as well. But checking circulation to the casted extremity is very, very necessary. So if you have the cast from here to here, you have to look at the fingers. Are they bluish discoloration? you have to check the radial pulses to see are there pulses, or the cast is on the leg. You have to check the pedal pulses. You have to make sure the blood is flowing. That's what you follow up with the cast. Okay?
Okay.
All right.
So when
Thank
it
you.
comes to fractures and casts and all those bandages, you're worried about circulation. There's no airway there. Circulation impairment. Now let's talk pharmacology. Pharmacology and parenteral therapies. I did another video on that. I don't know if I posted it. So you are worried about medication adverse effects, blood and blood product. Did we watch the video I sent about blood and blood products? Or did I send it? Did I ever send a video on the blood and blood products? Did anybody get to watch that video? I spoke about the various types of transfusion reactions and how much time it takes. Some are 72 hours, others start right away. So we have the central venous access devices. This is the midline, peak line, and all those lines. Dosage calculation. So you know that those central venous access devices, they will always want to know how you do wound dressing. They will put those questions in drag and drop, and they want you to arrange them how you do a wound dressing, how you dress a midline, how you dress a tracheostomy care. They'll put them drag and drop. Dosage calculations, yes, I want to talk about that one. Expected outcome, expected actions and outcome of medication, medication administration, pharmacological pain management, parenteral intravenous therapy, and total parenteral nutrition. Now, most medications, they use brand names for, they use the generic names for the Nclex. Example, who is going to read this one for me? I'm just tired of talking. Patients, are you on? Patients? Gertrude, can you read for me? Gertrude? Gertrude, are you on? I think she's here. You're dozing off? Gertrude, are you reading? Oh, it's Emilia. Emilia, read for me. Okay, the LPN knows the client is allergic to an ordered medication. Which of the following is correct action by the LPN?
Oh, I was reading, not knowing I was muted.
Oh, I saw that you were muted. So, yeah. So the question says, the LPN notes the client is allergic to an ordered medication. You realize that this patient is allergic to this medication. Which of these actions is most correct? Or which of this is the correct action to take?
4. Number
Call the
4.
primary healthcare provider and report the medication allergy. Yeah, that's the correct action you will take. You don't have anything to do. You have to call the doctor and let the doctor know and report the allergies. Okay. So that was an easy one. A home health nurse is going to start an IV. Dextrose 5% water, that's D5, for a 78-year-old man. To perform the venipuncture, the nurse should start the IV with which of the following? Gertrude, this is your question. This question is for Gertrude, and then we are almost done. After this, we have this one, and we close. I'm sorry we didn't get a break today. Gertrude, this is your question. The home health nurse. Let me enlarge it a little. I want you to try to answer it. I give you the more complex questions to answer, you know. I don't mean to bother you. The home health nurse is going to start an IV with 5% dextrose for a 78-year-old man. To perform the venipuncture, the nurse should start the IV with which of the following? What do we understand by this question? Who has an idea what it wants you to do?
The location where you put the IV line.
Yeah. The question is telling you are going to hang D5 on a patient. And the patient is 78-year-old man. Which of these locations is more appropriate for you to put it? Gertrude, where will you put it? I know you do this every day. You see how sometimes Nclex they just pick a real life question that we do every day and they throw it back at us. So this question, don't assume the patient is a heart stick or the patient is something. No, they just want to know the right spot that you pick to put the IV line. Mm-hmm.
3.
3?
Yes.
Okay. Emilia, why will you do it? Gertrude said 3. Okay, I have a question. If I put my hand like this, which one is my forearm?
Between the wrist and the elbow.
Upper side.
Upper?
Oh, really?
Yes, there.
This side is my arm.
Mm-hmm.
And which side is my forearm? Clementina, are you talking about hand, arm, or forearm? Which one?
Forearm.
Where is my forearm?
Above your elbow.
From here up?
Oh, yes. From here up.
From here up.
Yeah.
And whose side is this?
That's your hand.
And whose side is this?
That's the
wrist.
back of your arm.
Not the wrist.
I'm not talking about here.
The dorsal.
Which side is this?
The wrist.
So that's not that's your dorsal.
This is my wrist, right?
Yeah,
I'm
your
not
wrist.
wrong. Is that my wrist?
Yes. It's your wrist.
Okay. What is my this?
The dorsal part of your hand.
Oh, Lord. Okay.
That's the dorsal side.
So the whole of this is my hand, right?
Mm-hmm.
It's my hand. So we have the forearm and we have the arm. It's the same, basically. So my forearm is all here, and this is the dorsal part. So they're considering the whole arm. They're not separating the wrist here. They're considering the arm. This is the dorsal part. This is where you put it, so that it doesn't distract me. For an old man who wants to be eating and doing his stuff. So this is the dorsal portion.
It should be on the non.
But if you want to talk about hand, this portion is the hand, the metatarsal. This is the metatarsal region, is the hand. But forearm is the forward arm. It's not the back, the forward arm. So they can label it as forearm.
So the forward part is what?
Forward part is going this way. You don't go back.
No, from the elbow up to the shoulder is what?
It's all your arm. That's your long arm. So from here to here, this is your shoulder. This is your shoulder, and this is your forearm going down. This is the dorsal part of your forearm. This is your wrist. This is the hand. From here alone is only the hand, but the whole thing is forearm. Okay.
So where would you put it?
You put it here. Number 3.
Okay.
The dorsal part.
Okay.
Yeah. The dorsal part for non-dominant hand. So if I eat with my right hand side or with my right hand, so my non-dominant hand is my left. I don't use it for a lot of things. So you can engage this portion and fine with that. So the veins of the client's wrist on the non-dominant hands, the veins of the client's wrist. You see those here, when you see people trying them, they are not the good one for IV, or they are not the good one for venipuncture. The veins of the legs, so it will not interfere with the client's ability to feed himself. Who know why this one is not correct? Number 2, who know why you wouldn't do that? Why wouldn't you put it on the leg? I'll tell you why number 3 and number 4 are different. Mm?
Mm-hmm.
Who know why you won't do number 2? Hmm?
Hmm.
Yeah.
Don't know.
Yeah.
Hmm? Hmm?
Hmm.
Okay, so number 2, you will not put the IV on the leg. You will not put the IV hand thing on the leg. Mostly with the legs, you are concerned about DVT. You're concerned about DVT as a complication. You know, we have the phlebitis and all those things, and it's a lower peripheral site. So I'm usually concerned about DVT. So mostly they don't advise you use legs for IVs, but if you have to use legs for IVs, you need a doctor's order. That's a place you would use as a last resort. Yes. So you use that as a last resort. And mostly you want to let the doctor know before you get an order for that. The dorsal veins of the client's forearm on the non-dominant side, the dorsal vein. So here is easier, it's pretty easier to use here. The dorsal veins here, not the inside ones. The dorsal veins here are pretty easier to use, and they will always show up, because when you make a fist like this, you see them appearing. It is easier to use these ones. Mostly, I know you have seen the phlebotomists use the brachial vein and all those things. That's the major vein. Usually, they don't want to tamper with it. So for the purpose of the Nclex, this is good to use as a peripheral IV. This is good to use for peripheral IV stuff. I know back in Ghana, mostly they use here, but in here, people do it from here, from the wrist. But this is the most preferred site for IV. The dorsal surface of the client's hand. Dorsal surface of the client's hand. This is what they are talking about. Dorsal surface of the client's hand on the non-dominant hand. So this is what I just explained. That's why they don't use this side. This one has the brachial vein and all those things. But the most preferred area is here for peripheral IV. So take note of that. That's why they don't use the number 4. Can we talk about risk reduction and then physiologic adaptation, and we are done? I know we are tired right now, but let's finish up. So reduction of risk potential, changes or abnormalities in vital signs. Okay, changes in abnormalities of vital signs. So you should know when my blood pressure is dropping, it makes sense to elevate my legs. Diagnostic test. That's why when I pick a topic, I talk about the diagnostic testing that will be done for that particular topic. Lab results or lab values. Potential for alterations in body systems. Potential for complications of diagnostic tests, treatment or procedures. Potential for complications for surgical procedures and health alteration. System-specific assessment. System-specific assessment. If you remember this, I told you, especially those I did the GS system with, I said system-specific. You want to know that the symptoms that are presented in GI will not be the symptoms presented when the cardiovascular system is affected. So system-specific. Therapeutic procedures. Now let's answer this question. So these are the same questions. So I'm going to have us read only one. So Beverly, you want to help us read?
Parents bring a school-age client with a history of type 1 diabetes and several days of illness to the emergency department. Which of the following laboratory test result would the LVN expect if the client is experiencing diabetic ketoacidosis?
Good. Diabetic ketoacidosis. I spoke about the lab results and what should be normal and abnormal, especially I did for urinary system. I didn't give you the general blood work for complete blood count and complete metabolic count. But I remember I spoke about the pH of blood. The pH of blood. I don't know why I answered this question for you guys, but it's okay. So the blood pH is 7.28. Why? That's the correct answer though. Why would you use this laboratory finding to know? Serum glucose, this is normal. Creatinine, we are not worried about creatinine. So when they talk about ketoacidosis, it tells you the patient is in an acidic state. So your urine stuff and all those things is not what you be worried, even though you will get the urine sample, you follow up for ketones in the urine. But if you have blood that is giving you an acidic level of the patient blood, that means the patient whole blood is acidic. The patient is dehydrated. The cells are being constrained because it's all acidic. Hematocrit. Are you worried about this? No. And this is even a good number. So you are not worried about this. But this one is acidic and the patient is ketoacidosis. There'll be ketones in the urine and in the blood. You will see the acidic component of the blood. The normal pH of blood is 7.35 to 7.45. So if a patient has below 7.35, that means the blood is acidic. And if it's above 7.45, that's metabolic alkalosis. So this one will be metabolic acidosis. And metabolic alkalosis will be when it's above the acidic level. Can I move on to the last section and we close? Physiologic adaptation. So physiologic adaptation, you have alteration in body systems. Basic pathophysiology, okay. Fluid and electrolyte imbalances, illness management, hemodynamics, emergency or medical emergencies, radiation therapy, unexpected response to therapies. Example, who is going to read this question for me? I need a volunteer to read the last question. They are both the same. And then I want all of us to answer this question and we close. I need a volunteer to read, please. They are both the same questions.
I'll read it.
Yeah.
The LPN is delivering its external cardiac compression to a client during cardiopulmonary resuscitation. Which of the following actions by the LPN is best? 1. Maintain a position close to the client's side with the nurse's knees apart. 2. Position hands on the lower half of the sternum during compressions. 3. Lean on chest between compressions to prevent full chest wall recoil. 4. Check for a return of the client's pulse after every 8 breaths by the nurse.
Okay, so 1 minute for everybody to go over the answers and send me your answer. You can just post it in the chat room. You can post it in the chat room. Gertrude, I'm waiting for your answer. Patience, are you on now? I want everybody to send me your answer to this question in the chat room. Just text it.
Chat room.
Yes, Clementina, thank you. Who again? Who again? Emilia, are you on? Patience, are you on? Can we send the answer so that we close? Because we are done. This is the last one. What's the answer to this question? Nobody is talking. Okay, let me answer it. So Clementina did answer it correct. Thank you, Clementina. You position your hands on the lower half of the sternum during compressions. So this question is asking you to take up an action that is best, or what indirectly they just want to know if you know the correct procedure for doing a CPR for the patient, where your hands should be placed. They're asking to know if you understand how CPR should be done. So if you don't understand, when you are doing CPR, you have to put your hands just in the lower half of the patient's sternum, in between. So the lower half of it. That's where you put your hands and you do your chest compressions. That's it. Any question, any contributions, any subtractions, any additions? Okay, thank you. I see number 4. So check for a return of the client pulses after every 8 breaths by the nurse. Every 8 breaths by the nurse is wrong. It's not every 8 breaths. I'm going to go over that and I'll let you know the most recent instruction from American Heart Association. It's every 2 breaths. I've never seen 8 breaths before. It's 2 breaths after each compression. After each compression cycle, it's 2 breaths. So 8 breaths makes that answer wrong. So you want to wait to breathe 8 times before you start pushing. Then your patient will dry out. Any question? I have explained this one already. Clementina, you did miss that portion, but I had explained that on the Nclex, these are the only 2 levels you get that will make you pass. The recall and understanding, recall is just when you remember your content and you answer the questions based on your anatomy and physiological knowledge. Understanding is, yes, they just give you the question, and when you read the question, you just understand that if a patient has heart failure, the patient will have shortness of breath. That's straightforward. It's more of a recall. But where they give you a question to apply your knowledge, like this one we just answered, they want you to apply knowledge to be able to understand that this is what I will do that will be right. This question, they want you to apply knowledge, but you have to use the knowledge of ketoacidosis and which of the metabolic systems will it affect, which of my body parts will, or what are the signs, or what are the lab values I will see that will be abnormal to tell me that this is ketoacidosis. That's analyzing. So you have to be able to understand that the pH has a normal value, and if it's not normal among these numbers, and acidosis, you have to understand this is acidic component. So analyzing component and application level questions are those that will help you pass your exam. Recall and understanding does not help you pass, but we do have a 25 questions that are non-passing. They are just assessment, or they don't grade them. They are non-graded, but they add those questions there. So when you are getting all those questions like that, you are not able to determine which one is graded and which one is not graded. That's why on the exam, you treat all the questions with seriously, and you should do fine. So in all your studying you are doing with the content, you should be able to learn and understand how to analyze situations based on your knowledge for content. Like the question we asked about the blood pressure being 190/100. So you know 190/100 is not a normal blood pressure, but when you analyze it, you don't change the blood pressure curve. Your mind should tell you that this is not right and something needs to be done right now. So analyzing level at difficult level. Analyzing and application are difficult level questions. Delegation and prioritizing the task at difficult level to think about which one to do. And those are what will make you pass the exam. Are we done today? Thank you so much for coming. It's a pleasure, and let me stop the recording.